Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isaac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for a social conversation. I'm your host, Dr. Ronit Lev. Today, we're talking about social norms. Social norms are accepted standards of behavior of social groups. People know to be quiet in a library. That's a social norm. My kids went to an outdoor high school in San Diego. On a rainy day, they would not be caught dead with a raincoat or umbrella at school. That was simply not done. That would make them stand out. Getting wet on a rainy day was the social norm. Social media has introduced a massive new form of digital social peer pressure and perceived social norm. A post with many likes and comments may make people feel like they need to conform, and if they don't, they'd be quiet. Depending on what you're clicking and searching, it may seem everyone is drinking alcohol or using marijuana or having sex. But is that true? Is everyone really drinking alcohol and using drugs? And with that, let's hear the question of the day.
Hello, Dr. Lev. Thank you for bringing us High Truths. My name is Stacy Childs. I oversee a youth leadership program in California called Elevated, which is a project of SAY San Diego. Elevated high school leaders aim to improve community health, safety, and substance abuse awareness among youth. The youth leaders I work with always talk about mixed messages they receive in their environment. They see the normalization of marijuana, psychedelics, and vaping. At the same time, we want to protect their brain development. Our question is, what is the best way to combat this culture, and what are the social norms we should be promoting?
Thank you, Stacy, for your question and supporting the podcast. To answer your question on social norms, I have the father of the social norm theory himself, Dr. Wes Perkins. Dr. Perkins is Professor of Sociology and Project Director of the Youth Health Safety Project. He does research and provides strategies to reduce risk-related behaviors among youth and young adults throughout the United States and internationally. He developed the social norms theory of changing risky behaviors and edited the book titled The Social Norms Approach to Preventing School and College-Age Substance Abuse. His work has been featured in the New York Times, LA Times, CNN, NPR, New York Times Magazine, Newsweek, and Time magazines. Wow. And now he can proudly add High Truths on Drugs and Addiction podcast to his media accolades. To learn more about Dr. Wes Perkins, check out the High Truth show notes. Dr. Perkins, welcome to High Truths.
Thank you very much. Great to be here, Dr. Lev.
I'm very excited for our conversation. I have the developer of a brand new theory, social norms theory, to talk to. We're going to learn so much about that right from the source. But you're a sociologist, right? So
I am.
How did a sociologist come about to study the issues of alcohol, drugs, social norms? Tell us about your path.
Yeah. When my graduate training in sociology is part of it, I was a public health service trainee. That was part of my education within the Ph.D., master's and Ph.D. program at Yale. And so I was a public health service trainee. And so that put me on that track, if you will, toward public health. And also one of my major specialties was social psychology and youth, adolescent, and adult development. So those blend over a lot with psychology. I do a lot of work with psychologists, and I teach social psychology. but as a sociologist, come at it a little more from the side of normative influences, cultural systems, and how that influences our behavior. And then, of course, I was very much interested in health concerns, and I was also I did an internship, or a year internship training, as part of my graduate education in an alcohol and drug clinic in a mental health clinic in Connecticut. And so I had a lot of experience kind of working firsthand, did a lot of work with children of alcoholics too. But the children were teenage, late adolescents, young adults, and so forth. So in that context, I was already interested in this before I finished my Ph.D., and I was doing work on age development and cultural influences and so forth. So that's set me up for it. But it was really when I came to be a college professor that I got into the work in detail about risk behaviors with late adolescents, young adulthood, and particularly with college students. But we may talk about that more as we go along. So that's the basics of who I am. And
so it sounds like the government kind of put you on this very path when you were very young.
Yeah, actually, they did. They did. That's true. Yeah.
So I call you the father of the social norms theory. So tell us, what is that? What does that mean?
Yeah, well, the father of it was, I think that was dubbed that by an article in the Los Angeles Times a long time ago, because while myself and a clinical psychologist at my institution, Alan Berkowitz, we initially discovered the phenomena of massive misperceptions when we were doing some research on studying alcohol problems at our institution. And we were studying college students. We were at an institution, like many schools in the Northeast, where alcohol use was a significant problem, heavy use was a problem, and so forth. And had already known that alcohol abuse was the biggest problem for college student populations, and it still is, and so forth. So we were interested in doing that and studying patterns and conducting surveys in doing that. And at the time, we stumbled upon almost this serendipitous finding that while that the problem rates were substantial, the actual majorities of students on campus were not consuming at risk levels, were not a problem, and so forth. But they thought everybody else was.
Is that true even for the party schools?
That's true for every school we've studied across the country, and I tell every place that I speak about this, I will bet my paycheck that there'll be a massive misperception. A lot of schools think, oh, not us. We're in the top 10 on the Playboy list of heavy drinking schools or something. But it's remarkable how hundreds and hundreds of schools will say that, and how can they all be on the top 10 list? There is this notion out there that, and it's certainly true that there are many schools who struggle with a problem of substantial alcohol misuse in their populations. But again, it's not the majority of students. And so consequently, but what we simultaneously find when we were asking students what they thought their peers did, what was most typical, what they thought the norms were with regard to behaviors and with regard to attitudes, they consistently said in our early studies that they thought everybody else was doing much more than what would really be revealed by the aggregate of personal behaviors and so forth. So it was a curious finding at first, because nobody else was really asking those questions when we first, I say, almost stumbled onto this. But we thought about it quickly and thought, well, this might have some prevention value to it and so forth. And from there, I took it further and developed a whole kind of theory of why these misperceptions emerge and how we can apply them, the dynamics of them, just using the general information out there about peer influence and how powerful it is, but then taking into consideration, are we talking about the actual influence of peers, or are we talking about what we perceive to be our peers, what we perceive our peers to do? And in the long run, we find consistently that not only peer influence is extremely powerful, but it's the perception of peers that trumps the actual the behavior and attitudes of peers. So I developed a theory and background, and then a number of people in the field began to creatively apply this approach. We did it on our own institution. Other prevention health educators, prevention workers, and researchers began to apply it. Another at the beginning, college and university settings began to get positive results in introducing interventions from this theoretical point of view. And then it began to move into high schools and middle schools and take into other populations as well. We've done work with the U.S. Air Force, for example, and their young adults in the Air Force because they were having problems. And it's been applied to other kinds of substances, and the same patterns emerge that however big the problem is, by far it's overestimated, but that overestimation has a perverse, if you will, feedback effect on individuals who are engaging in the behavior, encouraging them to do it more. And it also encourages or discourages, I should say, those who are not engaged in the misuse or risky behavior to not speak up, to be passive bystanders instead of active bystanders. So it prevents them, or at least detours them in part, from intervening. So this misperception that is out there is, I liken it to in a disease model sense, that it's contagious. It's passed around to other people in conversation, and it, in the long run, discourages more of the healthy behavior that could be taking place, and it encourages the risk behaviors because that's what we think our peers want us to do.
That is fascinating. And Wes, you're like my new favorite person of making analogies of infectious disease. My listeners know I'm always coveting COVID and STIs and other infections.
Well, it's important. I refer to people. One of the problems in the ways that this misperception is spread is that even though people who do not engage in the misuse of whatever substances we're talking about, and people who even would never engage in it, some are not engaging, but they might, and they get influenced by the misperception and encouraged to go along with what they think the group thinks is most valued and so forth. But those who would never get involved, as I said, they stay silent. But one of the things that they also have is they are infected with the misperception, to keep with the disease models you're saying. They're carriers of the disease, in the sense that in their talk with other students, whether we're talking it's a middle school or a high school or a college population or new cadets, airmen entering the Air Force, or any of the other places we've studied this, they, even if they wouldn't do it, when they in essence begin to interact with the new students, they say, well, I don't do this, but everybody else goes out and gets hammered on Wednesday nights, or I don't take this substance, but most of the people here, I don't use cocaine, but most of the students here are using cocaine. So, which is an incredible misperception. We know that while cocaine use is a problem, I'm just using this as an example, the vast majority of students in college populations are not using it. Certainly that's true in high schools and middle schools as well, but it's remarkable that this phenomenon of the people who are not using will say, I don't do it, but everybody else does. And to that extent,
that's so true. I have that in my own family. When my daughters were in college, everybody's using marijuana, but and they don't. And then you're right, they're going to be quiet about it, because if they perceive marijuana use as a social norm, they're not doing it. They're just going to be quiet. And
exactly.
All right.
Exactly. And they may even pick up the drink and hold it and contribute to the misperception that everybody out there at this party is drinking, or something like that, if that's because they think everybody else is, and they're more comfortable holding the cup or something like that, because of their misperceptions. And then when they talk about it with other students in classes or in social situations, and they say, well, I don't do this, but most of the students do it. The RAs, resident advisors in college populations, in the residence halls and so forth, are typically for the most part, models of good behavior in their own sense, but they'll tell their students, well, I don't do this. We're not supposed to be doing this, but most students here will do this. They infected with a misperception, they pass it on, and then it has a toxic effect on others.
So the social norms model of prevention would be for that RA to say, I don't use it. And guess what? 78% of college kids don't use it as well.
Absolutely. Absolutely. It's saying, look, the best research we have, the best evidence we have, and most schools have the data. It's the best kept secret that the data about what the actual patterns are of attitudes and behaviors is, I liken it to vitamins. It can be good for students to know the data, but we keep the information about the positive majorities in the medicine bottle, keep it on the shelf till the shelf life expires. Until those students leave, and they never hear about themselves and their peers and how many of them are in fact holding positive attitudes and exhibiting positive behaviors.
I love that. I heard you speak as part of an ADAPT conference on teaching primary prevention. They were doing this for HIDTA, the high intensity drug trafficking areas. And when I heard your video, I thought, wow. And I started incorporating the social norms approach to primary prevention teaching. So thank you.
Yeah. Great.
Now, when you talk about that, I've heard you say you don't like scare tactics, that they don't work. You called it health terrorism. Is that really true? Because I think it may not work for some people, but I think I remember me as a little girl, if you told me that your brain's on drugs and an egg, this is your brain on drugs, and they show an egg in a frying pan. First of all, I didn't understand it, but when I did, that scared me. It prevented me from, doing anything risky. So maybe it works for some people, but not for the majority. What's your theory on that?
Well, I mean, there's a lot of work that a lot of research out there that looking at scare tactics and scare strategies, and the evidence of them having a positive effect is pretty thin. Occasionally, you might find a study that shows some evidence, but it's really rare to show the kind of meta studies of scare tactics, interventions, and all are not positive in their approaches and so forth. And I might not be popular in saying this, but like the DARE programs were examples of that initially when they were coming in and talking about all the problems and all the things that students were doing and so forth. They were good for police relations with the schools and the students, but they didn't reduce the risk behavior problems. And there's been several studies demonstrating that. They've more recently started to incorporate, from what I've seen, some training and emphasis in talking about peer norms and the actual norms, which is the way to go, as I would suggest. But to simply launch information about don't do this, or these are the bad things that are going to happen to you. Well, yeah, I can appreciate, as you're saying, well, I didn't do any things. I didn't do any of those things either, but it really wasn't. I was shown in growing up in middle schools and high schools, the black lungs and in the formaldehyde bottles, and we all went through that,
Yeah.
But that didn't stop youth from smoking and that sort of thing. What I would suggest, the real downturns, part of it is regulation and part of it's limiting the types of advertisements and so forth. But also when we saw the real downturns, and here's where kind of social norms mixes with legislation and social control, is when we started, for example, limiting space in restaurants. I can remember when there would be a little one or two tables at a restaurant sequestered off as smoke-free, and then there would be people asking for those tables, and so they'd make a bigger cordoning it off, and so forth, and there would still be more people asking for those. And the line, then they'd have a small room, but there would be a line of people waiting for the small room, until we finally emerged to the point where restaurants were making the big room for the non-smokers, and then finally saying, well, we're just going to eliminate smoking in totality in the restaurants. The point of this is what's going on there. We're making it visible who the majority are. And people could finally see this. It's not the black lungs scaring them, but they can see that most people don't want this. They don't want it in their face. They don't want it. They don't think it's good for other people and so forth, in a kind of what I would call a visual histogram of the distribution of people as they looked and saw the majorities in the restaurants, and those areas were not choosing to go to the smoking areas. So consequently, that's when we saw this kind of big shift in society and in the patterns of things, when we are able to grasp the fact that the majority are not in favor of this and the majority don't practice it. So the other thing I would say about the question about scare tactics is, when we say, I also call it a kind of death education, don't do this or you're going to die, don't do this or you're going to die. Certainly, I'm not diminishing at all the great tragedies that happen when somebody overdoses and the deaths that occur, or when somebody's drinking and driving and the deaths that occur that way. Those are major killers of young adults and so forth. And I understand that. I'm not diminishing that. We have to be concerned about it and so forth. But the problem with just making those scary warnings and those messages is that they're based on a behaviorist model that in psychology that's based on, well, we're going to avoid punishments and seek pleasures. If something's going to harm us, we're not going to do it. If we're told, don't put your hand on a hot stove burner or you'll burn your hand, we don't want to do that if there's those kinds of warnings and so forth. And moreover, we can learn vicariously, humans can, to not do things by seeing other people being punished. We don't have to cross over the invisible fence line like dogs do when they get trained not to cross over the line and so forth. But we can watch others experiencing those punishments and decide and not do it. That's all true. And that's kind of the behaviorist model in psychology of learning through rewards and punishments, or the punishments of others. And we're creating warnings about that. However, psychologists will also tell you in the behaviorist, those using the behaviorist model, that if people are going to learn from either rewards or punishments, it has to be fairly consistent. It has to be fairly consistent for that learning to take place. So consequently, if a dog or cattle bump into a fence and they're shocked by it, they learn quickly not to cross over the fence or the invisible fence line. But if that fence was only turned on once or twice a year, they would just be walking over it all the time, even though some are shocked by it. That's the same thing with humans, who are animals too, and learn in some of the same ways, that if it only happens rarely, that we tend not to learn from it. And we can say, don't do this or you're going to die. But the real truth is, most of the people who engage in that behavior, really the overwhelming number of people who engage in most of that behavior, are not going to die from doing it. And so when we show this and say, don't do this or you're going to die, it doesn't translate and shape our behavior as we think it should. And moreover, we can ask students, we did in focus groups, what do you think we should do? And they'll say, show us blood and guts, show us the horrible things. And yes, we create messages, images, and so forth, and they voyeuristically look at those. But in the long run, they don't translate it. It's not going to happen to me. It's probably not going to happen to me. That's not going to happen. And most of the people they see engaging the behavior, it's not happening to.
Wait, so are you saying kids want to see the black lungs and the deaths?
Well, I don't think they're past the age of the black lungs and the formaldehyde bottles, but they'll say, show us the horrible things that happened, the carnage on the highway, or the crashed car and those kinds of things. And they'll voyeuristically look at them. But in the end, how many times will they get in a car with somebody who's been drinking, or they're drinking and driving themselves? They're probably going to make it home that night okay. And I don't mean that please anyone out there listening, I don't mean that to say it's okay. Obviously not. I've said it's a major killer of youth and young adults, and we would not want that to happen to any of them. But the truth of the matter is that the likelihood that negative punishment is going to happen to them is relatively small. And the interesting thing is when we use those strategies, and it doesn't work, often prevention people will scratch their head and say, what should we do? And the kind of response is, let's make it scarier. But the problem is, in making it scarier, you're making that result, whatever you're showing as the result, even less likely, even less frequent. And so it's less connectable to people in terms of, is it really going to happen to me? I would argue you're better off, if you really want to use some kind of negative consequences as a deterrent, it should be portraying something that happens rather frequently and consistently in order for it to have some kind of deterring effect.
Interesting.
So
what about the reality? Like, there's one pill can kill, DEA message about fentanyl. That's true.
That is true. Yeah.
So what do you, is that scare tactics? That's just reality.
Yes, and in a sense, fentanyl is a tricky drug in this sense, and I think the verdict is out in what kind of messaging we can do for that. But it's certainly the case, and young people need to be educated about it. But for one thing, many times they'll take it not knowing what it is, and certainly in younger youth, that's the case. They're taking it not knowing it. So it's while they're taking a substance that they don't know what it is, and they shouldn't do that. They don't know exactly what it is, and so that's a problem. And for the whole community to be educated about that is certainly important. But in a traditional sense, if they're taking just whatever the substance it is, just like being handed a drink or being handed another drug or being handed something to vape or whatever, if they think that, oh, everybody here is doing that tonight, it's okay because everybody else thinks it's okay. I'm not sure I want to do it, or I really don't want to do it, but everybody else is expecting me to do it. Then they get pushed into that. And that is the big misperception that we really have to counter, because we know peer pressure and peer influence is so strong. The prevention field acknowledges that, but there's in general, many do not acknowledge the misperception of the peers.
What's the difference? What's the difference between peer pressure and social norms? Is there a difference there?
Well, there's not. The distinction is there are social norms out there that guide our behavior, and so there are social norms out there. We could say, like driving on the right side of the road, and those are clear norms, and the vast majority of people do that. And we get in the car and we drive that way because everybody else is doing it, and it does influence us. The distinction here in what we call the social norms approach is making that distinction between what are the actual norms and what are the perceived norms. Because what we're talking is what's guiding us in the lanes of substance use, to use the analogy, is not the actual paint on the highway, and not the reality that 99.9% of people drive on the right side of the road. It's our perception of where they're, what lane they're in, and so forth. To go back to one of the kind of posters that I've used in examples and critiques, prevention strategists, by the way, often will contribute to the misperception. A poster that was put out for students in an anti-smoking poster many years ago in an Illinois initiative, and it had a whole bunch of fish on the page, and they were all kind of gray and withered, but they had cigarettes in their mouth, and they were all swimming one way. And then they had one brightly colored healthy fish swimming the other way and not smoking, and the tagline was "Dare to be different." And, when you think about that, the message of that, telling everybody that all the rest of your peers smoke, but you've got to dare to be different. And the DARE program itself was kind of in that message genre at the beginning. And what we really need to give the message to is, if it's the fish or the imagery of that, you got to swim with the current, but you got to know which way the current's going. And we should have been showing 90 or in true statistical terms, we should have been showing at least 80% of those fish being bright, colorful fish swimming one way, and 20% being withered up and smoking swimming the other way. But we distort the image in the wrong direction, and so that's the difference. And so, for example, in putting it back to actual research, I've conducted a lot of research in high school, middle school populations, in college populations, and so forth, where we'll look at and we can see that there are differences in the actual norms at different schools. I mean, in some schools, use of a drug is higher than it is at other schools. And when we've got a lot of schools we can compare, we can see what influence the actual norm has on the individuals. And sure, if you go to a school where there's higher use, you're likely to use more yourselves. There's more availability, there's more students doing it, it's even more visible. But the key factor, the biggest explanatory factor, is what the students in their own minds think their other peers in their school are doing. That, for example, explains about 90% of the normative influence, if you will, the perception of the norm, and 10% of the normative influence is what's actually going on among others in that school.
So the social norms theory for primary prevention is to dispel the perceived norms that people have and replace them with the actual norms that model good behavior.
That's right. And can you do that simply, or are you going to change people's minds overnight, or with one poster during Alcohol Awareness Week or something like that about what the real norms are? No, you have to produce a lot of information about what the true norms are, because they're getting a lot of misinformation from the forces that cause those misperceptions. Come at kind of three levels, as I argue. That part of it is psychology. I told you I was a social psychologist, and both are psychology and sociology going on here. That part of it is the brain plays tricks on us when we observe things and we don't know people well, the people in public and so forth. We see them do things and we can't account for it or contextualize it. We tend to think they do it, that's what they do all the time, or it's typical of them. So when we see somebody engaging in high-risk behavior, and we notice visible behavior, those kinds of things are very visible and so forth, we tend to think that that's what they are doing and others around them are doing more than is the case. So the brain there's attribution errors is what we call it. And so that's going on. And then the conversation that takes place is about those extreme behaviors. I always say, you don't hear a young person get up the next morning after a party, after the prom or after a college party or whatever age level, and come downstairs and say, boy, I can't believe how many people were sober last night. They don't say that. When I say that, usually people will smile or chuckle because it sounds funny. Or I can't believe how many people were abstaining last night. They don't say that, even though it's the statistical reality. Youth I
think that's true for negative things in general, right? Like I know that I'll have a great day. I'll see 30 patients. I did good. There's one patient that was particularly belligerent and ruin your day. And it's dismissing the 29 other people who are really nice.
That's right. And so to take your example, and so what happens is you go into the coffee or lunchroom with your colleagues and you talk about that and they say, oh yeah, there was that one for me. Mm-hmm. And the conversation, which I was saying is another thing that amplifies the misperceptions at whatever level and what other context. And you're right, it happens with regard to a lot of things. The conversation is all about those who are the extremes and often the problematic ones. And it does this, by the way, this approach now has been applied much further than just alcohol and other substance misuse. It's been applied to, we've done work on bullying, and yes, bullying occurs. It's a serious problem. About 25% of kids in schools engage in bullying to some degree, but it's not the norm. And yet most students think that, oh, everybody else does this, and so forth, and they remain quiet, they remain silent, and they're the carriers of the misperception again, and so forth, and they won't intervene in bullying situations because they think they're loners in this. It happens with seatbelt use, for example.
I was just going to give a car example, because you're driving down the freeway and somebody cuts you off and they're like, everybody's such a bad driver. It's like there was one bad driver, not everybody.
Yeah, exactly. Right? And we've got data out there, studies now showing that youth will at least use their seatbelts 80-90% of the time, but they think others use them maybe half the time, maybe less than half the time, and that sort of thing. And so while they may buckle up when they get in the car and drive, are they going to ask the person in the other seat or in the back seat to put the seatbelt on if they don't think anybody else does it? They don't think anybody else cares. They don't want to embarrass themselves and others by telling them to put the seatbelt on, because of the misperception. So it applies in a lot of areas. We've seen it and done research on it. It applies to sexual assault behavior and so forth, and other kinds of violence. And then it can apply to a lot of other kinds of research in public health. There's studies going on with hand washing, with bed net use for prevention in other countries with mosquitoes and all kinds of things like that. It is really, this approach has expanded dramatically in the public health area, and in other topics in other countries too. So, but the phenomena. So the last part of this that I was saying. So talk expands it. I always say, you don't go to a party and come home afterwards and the talk is about how many people were using the substance or doing this or doing that and so forth. They're not talking about how many people weren't. And you don't act like an anthropologist and run to the bathroom and write field notes about what everybody did, or like a survey sociologist and pass out surveys at the door to get an accurate cross-section of what was going on. You just talk about the extremes. But then the final part of this is the cultural level, where of course we have ads, we have entertainment that accentuate the risky behavior and so forth. But in addition, the news, if it bleeds, it leads. In the news, what does it report? That the 1 or 2 or 3% who are experimenting with a new designer drug, or the 5% who are using the cocaine, or the 5% who got in a big fight at the drunken fight at the football game after the football game or something, or the 20% who have clinically been identified at risk in terms of their behaviors and so forth. I'm talking about among youth and so forth. And so what happens is, well, when you say, oh yeah, let's say with college students, oh yeah, there's 20-30% have been identified as binge drinking, or 10% gotten involved in a big incident, or 5%. Oh yeah, all those lots of college students do that. Oh yeah, most do. Oh, everybody does. It's like that game of telephone you used to play as a kid. When it's passed along and talk about it, gets changed completely. You don't remember, but you remember the story about how problematic it was. But of course, we don't hear the news stories about 97% of the students never using that new designer drug, whatever it is, or 95% not using cocaine, or 80% not being at risk in a youth or young adult population, and so forth and so on. We just, because that's the way the story is told.
It's interesting. That's kind of like, Dr. Bob DuPont. Is our previous drug czar for the United States and psychiatrist. He has a one-choice program, and he emphasizes what you're saying and showing in a graph form that over time, more kids are choosing to make the one choice to protect their brain of not using any drug, not nicotine, alcohol, or any drug. And so he has the data from 12th graders over time, and the number of 12th graders over time who choose not to use any of these addicting substances is going up.
Yeah. And so to the extent that we can publicize that and talk about that, and we kind of talk about that as trending norms. Sometimes if you have a measure, one of the problems is that if you're oriented toward needs assessment, you want to promote the biggest, use the measures that show the biggest problem and so forth. And I understand that because you want to get support from politicians, from parents, to do interventions and really address the problem. But at the same time, you can choose measures. Have you ever used alcohol in your lifetime? And you're going to find majorities of a population of 12th graders will come into that category. But if you say, well, what about in a typical week or in the last 30 days or in the last, whenever you go to a party or when you're in this situation, overwhelmingly, the vast majority of populations and youth ages and so forth are not going to be in those categories. And we should be using those kinds of measures and talking about the positive majorities. But just back to your example, the fact of so taking just the 12th graders, well, that's the highest end of the high school. So it's pushing it, but even there, we see, as you say, that the percentage who are not using has been growing, and that's an important kind of thing because students will respond to what we would call about trending norms, that it's becoming the norm because it's becoming more popular, and you want to follow which way the peers are going. So we might as well emphasize that as well. And so I think it's a good thing to be saying that.
Yeah. So Stacy Childs is a prevention specialist in San Diego. She works with youth, and she has a question.
Okay.
She's asking, what is the best way to combat normalization of drug use? I realized hearing you talking, that's what the marketing people like, oh, everybody prefers Coke over Pepsi, or everybody's drinking beer and everybody's smoking weed. So the industry that's selling you, promoting, is using these, perceived social norms or filling your head with social norms that may not be true in order to sell you whatever it is that they're selling. It works for anything. And there is, I think, a movement in the United States now to normalize drug use. And so she's asking, what's the best way to combat that?
Yeah, well, the best way to combat that, from my point of view, or the social norms approach strategy, is to essentially do what the marketing and media and advertising people are doing. The only difference is we're telling the truth and making that point. It's another type of truth campaign. The truth campaigns had some positive effect with them, but it's another type of, we're telling a pervasive truth. And so communicating what the actual norms are, both attitudinal norms, what students or young people or adults in general think is right, and what they actually do, the behavioral norms, communicating both of those with credible evidence and frequently providing that information. That is, the dosage has got to be high, because the dosage of misinformation about what the norms are subtly and almost directly is very large. So you have to have a lot of credible information, and we need to give the people, whereas usually the information about the source is a little small tagline down in the bottom of a let's say a poster or a message about, but I always say make that bigger and tell people, tell young people how many people participated in this study, where it came from, give them evidence, because the more evidence that comes with a kind of credible connotation, the more effective it's going to be. And
that's a good tip.
And the more we deliver it too, because we can do it. A lot of the strategies we started off with were print media campaigns, and they're still important because they still see, young people still see a lot of print media where they go here and there and so forth. But a lot of it can be and is digital now as well. But we not, in addition to that, we can bring these messages into curriculum infusion. teachers can be providing this in their examples in their math classes or in their health classes or in their, social, even sociology courses that are in high schools now and so forth. They can be giving these messages in as examples in what they do and teach. Instead of, sometimes teachers and faculty are perversely contributing to misperception. They may positively say, oh, this is a big weekend, I know, but your assignment is going to be due on Monday anyway. I'm going to maintain that, or I'm going to take attendance, or all these kinds of things, which might be a good thing to sort of help divert some of the risk behavior.
Right. But then you'd be like, I'd be the kid. It's like, oh, I wasn't invited to any party,
Yeah,
I will be
exactly. Exactly. But what often happened was that somebody will say, I know you're all going to go out there, whatever age level and so forth. I know you're all going to go out there and do this weekend, but it's due anyway on Monday. That contributes to the misperception because the majority aren't going to go do that. And we also know that with not just survey research, but we know it with breathalyzer testing, for example. Anonymous breathalyzer testing, and we've done that in our own institution. Other college institutions have done this. Late night coming home and testing, and having the data about the majorities aren't engaging in the risk behavior, and it's done sometimes in high school populations as well, although there's a little more complication with that in terms of parental permissions. But the biological evidence, in other words, is on the side of the majorities are exhibiting positive behavior. But
now, if is that even realistic? I mean, we are inundated with multi-billion-dollar industries who are pushing the opposite information for profit, whether it's for alcohol or marijuana, and other drugs. I mean, we don't have the bandwidth to give the right message all the time.
Well, okay, two responses to that. One, let me just add an additional caveat. I was saying the cultural level, there's the ads, there's the entertainment industry, and then there's the industries that provide the products and so forth, doing ads and so forth, as you're suggesting. And those are all contributing to the misperception. But as I said, the news does it as well. And prevention agencies that are promoting how, with their messages about how large and how many youth are engaging in this and the problem and so forth, actually inadvertently they're contributing to the misperceptions as well. So it's not just the problem of the commercial industries, although I certainly am not disagreeing with you. But having said that, the evidence is in the work that does take this strategy, because
the prevention groups are in there's a double-edged sword. They need to show that there's a problem, otherwise they won't get funding to deal with the problem, right? So they have that audience.
Exactly.
And on the other hand, when they're advertising their prevention message to youth, they need to use the positive.
Yeah, it's whatever the target population is, needs to get the information about the positive majorities. Yes, the research and data you collect for a needs assessment and wanting to get support, totally appreciate that we can demonstrate that and make that clearly and want to talk about that. But if we're trying to make changes among the target population, right, we need to give them the positive majority information. And your question about, well, is it possible given all of this? Well, yes, it is. We do have evidence. I mean, prevention work is hard and it's difficult, and most prevention work out there doesn't show any positive effect at all, or it's minuscule. We do have social norms interventions that do show positive effect. And in a variety of forms, in social media campaigns that have been conducted with social norms messages, also experiments being run with what is called personalized normative feedback, where online youth will be shown what the actual norms are, and they may punch in ahead of time what they're doing, and then what comes up on the screen compares themselves to what the rest of their youth or young adult population looks like. And when that happens, it either affirms what they're doing if they're doing the right thing, or it creates a cognitive dissonance because they thought everybody was with them in engaging in the high
That
risk
sounds
behavior.
really cool. Can you share such a link with me?
Sure. A lot of work that's been done with that kind of thing. A colleague who's a psychologist, Clayton Neighbors, and many others too, have been doing this. There are reviews out there of scores of studies now on what they call brief interventions, but and their effectiveness. But the key element in their effectiveness is whether it's a counselor sharing information, saying, rather than saying you've got a problem, saying, well, what do you do or what do you think? But here's what the evidence is about what most people in your category do or think, and where do you fit in? It's not pronouncing the judgment on them, but letting them see where they fit. And you can do that in counseling situations or in computer simulations, or in poster signs, but it's more personalized if they've said what they do or think, and then you can superimpose that over against the dominant normative distribution. That can be a very effective strategy. So there are these brief interventions and what's called personal normative feedback. They're all based on the key element that works is based on the underlying social norms principle of let's tell people the truth about the population and let them see where they stand within it, and also produce some cognitive dissonance there about what they thought was the case versus what really is.
I love that. I could see an app where you download an app and you go through little questions about yourselves, and the social norms pops up for you. That sounds really cool.
Yeah, we've done that, and we've done that in when we've done surveys of, let's say, student athletes. And we have already collected the data, but we know what the patterns are going to be. But maybe next year we do the study again, and at the end of the survey, we say, before you leave the survey, let's say they're doing it online, before you leave the survey, here's some information about what you said and how that fits in with the larger population of student athletes, which is their kind of peer group and so forth. And then they can see what they said from that very survey they just took in comparison with what student athletes in previous rounds of this survey have said, in a way to make this point quite vivid to them.
That is very cool. So Stacy has another question.
Okay.
And what are the social norms that we should be promoting today? And we talked a little bit about that, like alcohol and drugs, but what are some key things, in 2023 that we should be promoting?
Well, in 2023, one of the things we're talking about, you raised is this question about fentanyl, which is a trickier one because much of the problem, the overdose, is not through intended use, but they may eat some candy or use something they thought was another substance and it has fentanyl in it and so forth. But getting the message out that most youth do not use most youth do not use even prescription drugs that are not prescribed to them. Use of prescribed prescription drugs. I'm tripping over my words on that, but you understand what I'm saying.
Yeah.
That most youth don't do that and think it's a bad thing to do. But of course there are pills that are shared. And
are you saying, instead of saying don't use, like, this is what I do, and I'm thinking maybe I need to change my language. I say don't use a medication that's not prescribed for you with your name. It could be dangerous. I'll say there's no safe drug supply unless you buy it, from pharmacy with your name on it. Mm-hmm. So are you saying that the message should be changed to say most people don't do this, but then can you add because XYZ?
Yeah, I'm saying that maybe start off with that message. And then I'm not saying it's a bad thing to educate people that how certain drugs might be embedded in other medicines they're taking or they think are medicines and so forth. And and the kinds of things you're saying in some sense, and in some context, we have to give that information to some extent. But the key element, but to assume that's going to change their behavior, if they think, oh, then most of the kids that I know don't have those kind of the pills, that we all share pills and we're okay, and that's not a problem. And you can say, well, it is a problem, but the more important thing, I think, is starting the message off as, we know that most kids don't share pills, don't take pills that are not prescribed to them, and they don't think that others should as well. And this is why they do that. And then you can say what you just said. It's at least coupling the normative message with the warning, or stating the normative message first, so that gets clear, and perhaps educate them along the way about why it's a good thing that the majority don't do this.
Right. And what about the kids who have experimented or misused on occasion? Does that social norm still apply to that population?
Well, those who have used on an occasion, they're still interacting with and involved with the rest of the youth in the community or in the school and so forth. And yes, they may hang out with 2 or 3 other kids who are doing it as well. I'm not saying the most immediate peers aren't a powerful influence, but that being said, work with what you got, which is the power of the overall norm. And there, in many instances, they are with others. And some of the kids who are in those close knit or smaller groups where most of them are using, some of them don't want to be using, but they don't have the kind of mental strength, if you will, to not use. And what we're talking about here is, let's take the power of the social norm and use it in an effective way. Give them that information, so those that are on the edge of that group doing it once in a while can, if you will, peel away, because they start to understand that the majority of the kids don't want and like that. And then the ones who are using frequently, it may directly deter them in terms of when they find out they're not the center of the bell curve, and most others don't think it's cool when they do that. It may deter them, but even if it doesn't, then they're less likely, I would argue, to do it publicly, to do it in larger groups and show it off and brag about it. So in other words, those things that create the misperceptions, those people who are extreme being very public and bragging about it, that phenomenon is being reduced. They may continue to do it, but they're not going to be as public and bragging about it, which will help others who are on the fringe not get involved.
Right. That's a good point. So can you give us some examples of social norm campaigns that have evidence base that were effective, that, that this was applied to this population and it decreased use, drug or alcohol, and or prevented it?
Yeah, I mean, at my own, we've got examples at all kinds of levels. We published, I'm just talking about from my own research, for example, we at a middle school, we were doing one on bullying, for example, and that's published in Interpersonal Group Processes, the journal, that showed that when we would intervene in a school with messages about most of don't engage in bullying, they don't support the bullying and so forth, the actual bullying, the perpetrating, the reports of being victims and so forth, as well as the reports of perpetration, went down. And those schools who did more of the messaging there was almost a perfect correlation between how much messaging they did about the norm and how much effect they got, and so forth. That's just one example among many. In college populations, we have a number of studies out there, several studies out there that show, including in my own institution, I've done it with students in general and with student athletes, where we flood the public space with messages about the actual norms. We do curriculum infusion. You can even bring it into peer interventions where peers talk about the positive norms. So with athletes, we were doing it with peer mentors and so forth. And I have published articles about that in Journal of Studies on Alcohol, Journal of American College Health, and so forth. And I can give you my website will take you to a lot of examples of published articles that show positive effect. I mentioned that the personalized normative effect that goes on, Clayton Neighbors and others who are doing that kind of thing have many publications out there demonstrating this. Also, we have an article that we did that was in the state of Montana, doing it with targeting young adults 21 to 35 in drinking and driving, and comparing counties where we intervened and gave the message out about most young adults don't drink and drive, and the actual statistical facts that 4 out of 5 don't engage in that kind of behavior. Yes, it's terrible that 1 out of 5 do, but the importance is the message that 4 out of 5 are not. And when we did that, the counties that were getting a strong message, their perceptions began to change about what others typically did. The perceived norm began to go down about others typically drink and drive, and their actual practice, their use of designated drivers went down. And we even looked at crash data that showed there was a difference between the counties with and without the intervention. And that's published in let's see, the Addictive Behaviors, I believe it is, the Journal of Addictive Behaviors. But
are there
I'm just throwing out a couple there. There's lots of studies now.
There's a lot. Is there a place to go where people working in prevention can go and use some of these programs? So I had a podcast with Blueprints for a Healthy Youth Approach. I don't know if you're familiar with them, where they have you can go and purchase and apply some of these evidence-based prevention. I don't know if all of them use the social norm theory, but is there a place to go to say, I need a social norm approach for fentanyl, for marijuana? Where do I capture that? Or do we have to kind of build our own based on these principles?
There are many sites out there, and actually my websites can take you to those other sites, and on our site we have examples of the principles. We not necessarily with fentanyl yet, because that's something that's being developed. The ADAPT program that you mentioned, I think that you first heard me talk, is really focused on trying to address this and using a social norms point of view as well. But with regard to the other substances and so forth, yes, there's lots of. We have a guidebook that's free and available on our site. And there's a social norms primer section where you can see example articles. We have catalogs of example media and so forth for use in a variety of different populations that are directly available. And it also links to other sites and other programs that are using this strategy. It's alcoholeducationproject.org and youthhealthsafety.org are our 2 sites where we catalog and give examples and give references to publications and so forth.
We'll make sure to include that in the show notes.
Okay.
So primary prevention, very important. I'm sure that you are a fan. This is one approach, right? There's different approaches to primary prevention. This is one that's evidence-based, as you've given us all the different studies that show that this is important in preventing unwanted behavior by promoting the positive behavior that most people are engaged in.
It's basically, it's the most simple message I can say is let's tell the people the truth. The truth, will make you healthy and keep you healthy. But it's a spin on what, if not a spin in a sense of misleading, but it's a different way of thinking about the truth. That is the truth about the positive majorities. Let's use that to engage in prevention, because For one thing, it's readily available. The truth about the positive majorities are readily available if we actually look at the data from that perspective and turn it into positive messages.
Yeah, thank you so much. That is, and it is a different approach than many of us have been doing. I think it's important. I'm going to definitely try to implement that in my work as well. I want to say thank you to Stacy for your work in primary prevention, teaching youth, making a better, healthy future for all of us, constantly wanting to learn and do better in work, and inspiring a conversation as we're having today. Thank you, Stacy. And Dr. Wes Perkins, thank you so much for the social norm theory, important education and prevention, and the valuable resources that you have given us today. Thank you so much.
Thank you. I love talking about it, as I hope you see. It's something that you don't burn out. I tell prevention workers, when you're talking about something that's positive and it works, burnout is much less likely. So I continue to be excited about it. Glad you invited me.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to ISAAC, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit ISAAC1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.